All right, folks, let's come around the table, please. Okay, we're going to go ahead and get started. Okay, folks, we're going to go ahead and get started since we are running late here off the bat. So good morning, colleagues, staff. I'd like to call the October 19th work session to order. Today's work session will be split into two topics and is scheduled to end at 5 p.m. I don't know. I was going to say that we might end early if we're efficient, but I don't know that that's the case anymore. We'll see. The later portion will be about the program review and will begin at 1:30. I'll provide more instructions about that later on. We were scheduled to break for a 30-minute lunch at 1 p.m. Obviously, we'll check in throughout the session to see where we get. Right now, we're going to be receiving an operations and instruction update from Dr. Brabrand and staff. The focus of today's conversation really is about three primary topics. 1, vaccines, 2, testing, and 3, procedures for inclement weather days. Colleagues in the public are reminded that presentation slides were posted to board docs, as well as the job description for the Student Wellness Special Projects Administrator position that the board authorized at our last regular meeting. We'll begin with our staff presentations, followed by the usual round of 3-minute marks, and then, of course, we'll look at what we have for go-backs if we do. I do want to announce that one of our guests does have to leave at 12:30. So, Dr. Brabrand, I hope you guys take that into consideration, and then colleagues as well as you direct your questions. So with that, I'll hand it off to Dr. Brabrand.
Thank you, Ms. Omesh. Members of the school board, good morning. Happy Tuesday. Good to see all of you. I am very excited to bring this board a series of operational updates today. The core focus of our presentation will be on COVID testing, COVID vaccinations, and our approach to inclement weather days. Today, I am so proud to announce that we are being joined by our health partners here in Fairfax County, who have been collaboratively working with us throughout this pandemic and most recently have come together in collaboration and in unity to develop a shared plan and a shared commitment to ensure vaccine access for children ages 5 to 11 as soon as the COVID-19 vaccination becomes available, which we understand will be in a matter of days. It is my great pleasure to introduce first Mr. Colin Brody, who is with us virtually. He is the Assistant Public Health Emergency Management Coordinator and COVID-19 Response Director, and he will be here with us today. Mr. Dominic Bonayuto, he is the Director for the Central Region for ANOVA in Government and Community Affairs with ANOVA's health system. Also from ANOVA Health System is Joanna Fazio, who is Vice President of the L.J. Murphy Children's Hospital. I also want to bring acknowledgments that Dr. Michael Martin is here, who is President of the Virginia chapter of the American Academy of Pediatrics. I want to thank this amazing team for being here today, of course, with our Assistant Superintendent, Dr. Boyd. And we're excited to share our collective work that will use multiple strategies to best serve our community and allow us together in a united fashion to hopefully write the final chapter in this pandemic for Fairfax County and this community. First, I'd like to go to the first slide. On September 26, we saw that community transmission declined from high transmission to substantial transmission for Fairfax County. This is welcome news in our community, as the vast majority of the Commonwealth remains in high community transmission. We continue to see a decline of COVID cases nationally across the Commonwealth and here in Fairfax County Public Schools, And in our schools, we continue to see, as you can see by this chart, very, very low transmission in our schools. Our percent of positive cases remain with just over 1/3 of 1% of our staff and in-person students reporting COVID positive in the past month. Let me reemphasize that number. 1/3 of 1%. Less than 1/3 of 1%. While other districts throughout the country and in Virginia have had to deal with school closures because of COVID outbreaks, there has not been one case of school closure in FCPS. We have not had to close any of our schools. Our plan to ensure the continuity of safe in-person learning is working, and it is my intention and that of our leadership team, working with our health partners, to continue to follow our public health guidance. We will continue to follow the 14-day quarantine guidance at this time, but we will continue, it is my intention to continue to revisit the length of that quarantine in consultation with our public health experts after the vaccination for 5 to 11-year-olds is available in just the weeks ahead, and when we also hope to have more information from the CDC on the updated risk data associated with quarantine lengths. At this time, it's important to turn our attention toward the vaccination efforts for our youngest learners, as we know that's the most important strategy in our efforts to address COVID. So now, if we look at the low rates of students and staff who've been paused or quarantined as a result of being a potential close contact or a close contact and ultimately even being isolated, the rates for pause, the rates for quarantine, and the rates for isolation remain extremely low. Now, as I shared last month, while these numbers are exceptionally low, we recognize the impacts of a pause, a quarantine, or isolation on an individual student, a family, a classroom, and the impacts that come to a school and that they're difficult. Since we last met with the Fairfax County Board on this topic, we shared our stream-in check-in process that allows students who are at home in any of these situations to remain connected to the learning and to their school by having access to live stream instruction, as well as regular check-ins with their teachers and other school staff. We'll also be talking about today and taking additional steps with regards to surveillance testing, and you'll hear more about that information, which we hope will reduce the number of pauses, quarantines, and isolations. I want to share with you a next chart that I know many of you have been eager to see, and it is excellent data moving in the right direction. This is an update to what we shared last month on case lengths when people are out. And it's the lengthy wait time we all know that we've had when a case was reported and when it was closed out. First, we are seeing a decline in the total cases from week to week. That is the yellow line that is in decline. We also see a decline in the amount of time it's taking to close cases, represented by the blue line. It was at 10 days the very beginning of the school year. Now we're down a little bit under 8, a 25% reduction over the last 4 weeks. It is headed in the right direction, both in the total number of cases and in the case length. I want to turn our attention now to the vaccination planning for students ages 5 to 11. This is a key moment in our fight against COVID in our schools and our community. As you know, this board is aware the Fairfax community vaccination rates for adults are some of the highest in the United States of America. And we want to ensure now, in this moment, that we come together to best support our families who are planning, and yes, you will see, our community is planning to get their 5 to 11-year-olds vaccinated when the vaccination is available. Last week, Danny Avula, the Virginia State Vaccine Coordinator, indicated the first week of November is a realistic time frame from when we would have an approved vaccine for 5 to 11-year-olds. We know this opportunity is just weeks away, and we are planning and we are ready to respond. If you can look at our division-wide response data before developing these plans that we'll share with you today, we thought it was important to hear directly from our families regarding their intentions to vaccinate their child, the desired location to receive the vaccinations, and any challenges anticipated in assessing vaccines. The data from the survey was used to work with our health partners to best meet the needs of our families. We sent out a survey to all of our families who have children between the ages of 5 and 11. That's 85,000 students and their families. The survey response was 36%. We heard from some more groups than others, but we are digging into the data, as Dr. Williams would say, by pyramid to help disaggregate the overall responses and better understand how different families speaking different languages, representing different ethnicities and backgrounds felt. And this information will help us and our community partners continue to provide more targeted support as we continue with our regional mass vaccination and individual vaccination campaign. If we look at the division-wide survey results, we asked families if they plan to have their child vaccinated. 76% plan to vaccinate their child of those that responded, and 80% of those who plan to vaccinate plan to do so immediately. So our plans and this regional approach you'll hear about today will help us be ready to meet the surge that is coming as parents step up to vaccinate their children. 12% of our families responding were undecided, and 10% said they were not planning to vaccinate. Those that were not vaccinating, that small 10%, the common reasons cited were personal beliefs regarding vaccinations, followed by the emergency use authorization status of the vaccinations. We then asked families about challenges for getting their kids vaccinated. 45% were concerned that wait time to be vaccinated could be a challenge. 44%, almost an equal amount, indicated they would have no challenges in assessing a vaccination for their children. This data helps guide our decision, but we also know all families didn't respond to the survey. We asked families also if they'd consider having their child vaccinated during the day without a parent. Remember, this is our youngest kids, 5 to 11, without a parent or guardian, and of course, that would require parent consent. And while this was an approach many of our families welcomed for their older children, we were not sure if parents would want this approach for younger children. We were not surprised to see that this was a lower desire for this option. Only 35% of parents would consider having their child vaccinated during the school day, and 49% of our families said they would not consider that option at all. So finally, we asked families to rank order the preferred location for their child to receive this upcoming vaccination. The number one option is the child's family doctor. And I am thrilled to have Dr. Martin here to talk about how our pediatricians in this community stand ready to support our schools and families as this vaccination campaign begins. And Dr. Martin may have more to say, I'm sure, about that. The second priority was private local vaccination sites, such as local pharmacies. Third was a health department community clinic, of which there will be several. Fourth was a community clinic at the local school on the weekend, or perhaps after school hours. And fifth was a school-based clinic during the day without parent consent. Without the parent present, but with parent consent. That other option is the very, very last, not applicable for the survey. All parents will have consent for any vaccinations that occur in our community and schools. Families that responded to the survey indicated the highest preference, again, was for the child's doctor's office. I'm now going to turn it over to Dr. Michelle Boyd, our Assistant Superintendent for Special Services, to talk about how we've worked with our health partners to develop a joint plan to address the needs of our families. Dr. Boyd.
Thank you, Dr. Brabram. To continue, as we're filling in schools, the healthcare community is also strained. For our adult COVID vaccinations, emergency provisions were in place which authorized additional professionals to be able to administer the COVID-19 vaccination, such as athletic trainers and firefighters. That provision is no longer in place, which greatly impacts the ability to roll out vaccinations as quickly to our younger age group. This is why our collective efforts are essential in being able to effectively meet the vaccination needs of our younger students. This chart shows how each of our health partners and FCPS are bringing resources together to get our children vaccinated. The Fairfax County Health Department will be standing up mass vaccination sites at the Government Center, the South County Government Center, and Tyson's Corner. In addition, the Health Department will be partnering with FCPS to offer targeted pop-up clinics at school sites in the evenings and/or weekends, and also targeted school-based clinics during the school day. Our local pediatricians are also preparing to vaccinate this age group. A survey of over 20 practices serving students or children in Fairfax County indicated that 80% of them were planning to provide vaccinations in some capacity. This represents more than 200 of our area pediatricians who estimate they will administer close to 4,000 vaccines a week. INOVA will also be supporting this effort. INOVA will be opening up a weekend pediatric vaccination clinic at the Center for Personalized Health just down the street from here, where most of our FCPS employees receive their vaccinations. They will also be providing multilingual support through video messaging for FCPS families, as well as informational packets on vaccinations. In addition to the school-based clinics and weekend and evening clinics that FCPS will partner with the health department to offer, FCPS will also be providing transportation to support family access to mass vaccination sites. We've just reviewed the collective resources that will be leveraged by multiple partners to support the vaccination of Fairfax youth. Now we will look at the plan, which will show how the various resources will work together to support our students. As you can see, multiple opportunities will be provided to support the different needs of our families. We anticipate that access to vaccines will first be available through community sites, including pediatricians, health department sites, pharmacies, and mass vaccination clinics. In mid-November, targeted vaccination clinics will be held at schools in the evening and/or the weekend to serve as an additional resource to eliminate or reduce transportation barriers for families. This option also enables families to be present while their child is vaccinated, as this younger group may need the social and emotional support of their parent or guardian while they receive the vaccination. The vaccination clinics during the school day will start after winter break to ensure students are in school to receive their second dose within the 21-day window. We are incredibly thankful to our health colleagues, and we're so fortunate that they're here with us today, both in person and virtually, for this partnership that all of the work that they have done and continue to do throughout this pandemic, as it's not yet over. We've talked about our vaccinations, and now we'll shift at this time to talk about testing and the details about COVID testing programs that will be made available to students who are not fully vaccinated and required for student athletes and staff. But prior to moving to vaccinations, we'll pause and take questions and discussion regarding our testing program.
Right, and we know for the board, we have some of our guests that have to leave in just a little bit. This is the vaccination part. You've heard the full plan. Our partners are here, and we'll be glad to take any brief questions. But we are ready, we're prepared, and we have a coordinated regional approach to support our Fairfax County school community as these vaccinations become available.
Thank you. Thank you, Dr. Martin, for being with us today. So I do see we have Dr. Anderson, followed by Ms. Corbett-Sanders.
Thank you so much. This is very exciting information, and thank you for joining us this afternoon, or is it still morning? Yes, this morning. Just very quickly, Dr. Braybrand, I appreciate the survey. I completed the survey as a parent of an 8-year-old, but we didn't hear from the majority of our parents of that age group. How is this going to impact operations? And I know there'll probably be, well, you tell me instead of me telling you, what will be additional information that's going to be coming out to parents who may not have responded initially so that we can better plan?
Yeah, you'll see a full communications plan. I think it's just been dropped in your email in the last 30 minutes that we'll be giving out to parents, and be prepared to use that additional communications to make any refinements to our broad-based plan as needed. We know we didn't recognize everybody in the survey. It was just a weak survey to get the information, but I think what you see here is a multi-factor approach, multiple locations, really almost point of sale, point of vaccination locations, so that we can meet every family by name and by need when it comes to vaccinations for their children.
And thank you. You kind of dovetail very nicely into my second question, which is how will the locations for the pop-ups be determined? Because we're kind of invested in that in the Mason District because we needed to come to us.
Thank you, Dr. Anderson. We are going to be partnering with the health department and other providers to look at data in terms of community transmission, vaccination rates, so that not only does the survey serve as a point of reference for us, but we're also using that health data to inform what might be the best locations, and also taking into consideration what local vaccination opportunities are available in close proximity, so that we can make sure that we're building those bridges for folks who don't have readily available resources that are within accessible distance, that we highlight those areas as well. So it's a number of variables that we'll be looking at, as well as our school-based data, as you know, and areas for outbreaks and things of that nature.
Okay. Thirdly, some of our families may need some additional education around this. How will you propose that this will be handled? Are we going to be utilizing the parent liaisons, counselors for outreach to some of our families?
We'll absolutely be leveraging all of those resources, as well as just the ongoing communication. We know a number of our schools have those close relationships and are able to reach out beyond just our standard means of, e-notifies and things like that to reach our target family. So we will be doing that, and are also, as we shared before, partnering with INOVA to make sure that we are making some additional resources about the vaccination and what this is and what it means for students available. And I think certainly our partners, please feel free to just turn on your mics and add in as you feel the need.
Sure. So I think from a Nova Children's standpoint, we know that there are kind of two areas where our parents need help. That's, kids are always getting vaccinated, especially within these age ranges. They're used to shots a little bit more, or discussions of vaccines, than maybe some of the adults were that we struggled to get vaccinated. But I think we have a number of videos that are more like how to cope with the vaccine, how to talk to your child about getting a shot, how to talk to your child about getting a shot in a place where they may not have normally be getting shots. So if they're going to a mass vaccine center or a grocery store or any of those places, how to better prepare them from a child-friendly access perspective. So we're going to make all of those things available to all of our regional partners, including the schools, so you can send them to directly to parents. And then there's also the more targeted at parents, why it's important to vaccinate your child. In 5 to 11, especially explaining what EUA means versus the full FDA approval, and why this is a critical step, even though, like, quote, kids may not get as sick, why this is important from an entire public health perspective. So there are physicians that are making videos and putting together pieces that are more encouraging vaccination in general, so that we can get to that herd immunity that we all talk so much about, and why, even though kids don't get as sick, there are kids that have gotten very, very sick from COVID that we see each day in our hospital, and we're just trying to tell that story. I don't know if you want to.
Yeah. From the practice perspective, so VDH has made available resources for town halls. So I know a lot of practices have been doing, and I've done one last week, where we're doing town halls with the families and offering that up, recording them, so that folks, and as you can see from the survey, I do think we're the reliable first, which I'm happy to see, that we're number one on the list. So those materials have been pushed out both through the Department of Health as well as the AAP has a host of resources that practices are being given to get messaging out. And I've seen a number of practices, they're putting out messages. It's been challenging because I think what's for us as practices, with the volume of testing and illness load, and that shifts, and we don't know where it'll be when the vaccine comes, it is hard for practices to commit to X number, not knowing what the situation on the ground is going to look like. So I do think even in our survey, I think there's probably some conservative estimates there, and that there may be greater capacity than fortunately than initially indicated. So I'm hopeful about that. But I think each practice is dealing with different staff issues, and I think it's important to communicate to families that they should be reaching out for information from their practices. And most practices are starting to post and send out messaging about that.
Thank you. As you're engaging in such intense outreach to our parents about the kids, will these vaccination clinics, both the mass and the pop-ups, will vaccinations also be available to the parents themselves? Because this may be what makes the difference. Or is it just in a kids-only opportunity?
So we'll still be talking relative to the vaccination clinics that will be housed in schools. We'll still be partnering with the health department about that. I do know that when we did our vaccination of our older students, that was made available. But we do know that this is different, and you'll help me, different vials and things like that for our 5 to 11, which was different for some of our older students when we had the vaccine. So we'll talk about that, but we know that some persons may have evolved at this point and may now want to be vaccinated. Go ahead, Dominique.
Yeah, I think from an ANOVA standpoint, in all of our primary care locations that care for kids, so the Fairfax Family Practice legacy sites, along with ANOVA Cares for Children, we will be able to vaccinate parents. I think that's part of what our pediatricians and family practice providers are trying to do as they have the conversation to convince the entire family to vaccinate. At our Mass site, we will also have that ability. I think that actually from our perspective, the different vials are helpful because they take away the safety component of having multiple draws from the same vial in different sizes, which was our initial concern. So, but we're still working through the entire process for that, but it is our hope that the parents are already vaccinated by the time they come, with the knowledge that there may be some stragglers that we're able to catch and get the entire family at once.
No, and many practices were involved with vaccinating adults. I know I'm part of Trusted Doctors, which is a large number of practices in that. I think Capital Area did as well. I think for us, for many of us, it's gonna just vary in terms of staff and what we're able to handle volume-wise. The priority will be on children. I think some practices will be able to do some adults, some won't.
Thank you. And Dr. Braybrand, will we have our elementary school students then upload their vaccination status the way that we have our 12 and overs to expedite the quarantining, isolation processes? Or Dr. Bory?
Thus far, we do have the ability to enter that information as it becomes available, but it's a two-prong component as we talk about students who are, I believe Dr. Anderson is referring to, if students are fully vaccinated and asymptomatic and they're exposed to a positive case, they wouldn't have to be paused or quarantined. And it's that second factor, so we may be able to upload the vaccination cards, but we'll still have to have that feedback regarding the student being asymptomatic, as that's also a critical component in the process. And so we'll talk through that, but we need to make sure that both of those elements are addressed in order for a student to not be paused or to not quarantine once they've been exposed to a COVID positive case.
Well, thank you all.
And Mr. Brody, please feel free, we know that you're here virtually, to raise your hand if you want to contribute at all. We haven't forgotten about you there.
Thank you, I appreciate it.
Dr. Anderson didn't go over 2 minutes, so without objection, I'd like us to limit this portion to 2 minutes, and I just remind my colleagues, try to leave maybe operational questions, things like that, for your later portion, specifically addressing questions to our experts right now, because they have to head out pretty soon. So Ms. Corbett-Sanders, please go ahead.
Yes, thank you. And thank you so much to all of our health practitioners. You all have been heroes over the past 18 months, and I have a special place in my heart for the ANOVA team, having served on the Quality Board for Women and Children. You guys do great work. So, a couple things. One, I'm glad to follow up on Dr. Anderson about the uploading of vaccine data. I know that there is actually a Virginia State database for vaccines. What is the interaction between the Virginia State database for vaccines and our process here in Fairfax County for clearing students, and what can we do to ensure that everybody's vaccine data is uploaded?
Mr. Brody, would you like to provide some feedback regarding VIS and how that interfaces when students are cleared when they've been exposed to a COVID positive case?
Absolutely. So the system that Dr. Boyd was referring to, VIS, is the Virginia Immunization Information System. And that is the system that we use when conducting contact investigations to verify that a vaccine was received. That system, like many of our other public health information systems, is a closed data set, so that data is not shared outside of the public health community for public health purposes. But all vaccine providers in Virginia administering the COVID-19 vaccine do feed information daily into VIS for the patients that they are vaccinating.
Thank you. I just know that our high school parents are actually implementing or inputting the vaccine data in a separate database. And if we can kind of clarify what the difference is between the two databases, or uploading it so that the health department knows about that vaccine.
And Mr. Brody, just to confirm, when the parents upload their student's vaccination card, Viz is used to confirm that that is a valid and reliable vaccination card, is that correct?
That is correct. We have a number of different ways to verify vaccination status. Viz is obviously the most streamlined version, but there are other ways, including scanned copies of cards or uploads that are provided to us at the time of investigation.
So that's the confusion, because I know I've got constituents who are waiting, they're on pause, waiting for somebody to interact with them, and they haven't even been told where to input or update the vaccine information. So if you could get that information to the board members so that we can share it, that would be great. Secondly, on the communications piece, or lastly on the communications piece, I'm probably the only member of this board that was ever in an advertising campaign or a public health campaign in the 60s to promote getting the vaccine for the German measles. And so it was a very powerful experience, because they took pictures of me getting the vaccine and promoted it. I would hope that, given that we have multiple locations where students are getting their vaccines, that we would do everything in our power to show in our campaign to get students to get vaccine all the different places in which you can get a vaccine. So I see nodding heads.
Yeah.
That is an affirmation. We will be doing that. Thank you.
Thank you, Ms. Corbett-Sanders. Ms. Marin.
I'm so thrilled to see you all here, because it's two sides of the same coin here. You know, getting kids vaccinated is obviously, we need to prevent sickness and death. But we also need to provide for instructional consistency. That is, you know, our purview as well. So I'm wondering, taking it more of a macro level here, will INOVA or AAP be advocating in the upcoming to upcoming General Assembly members about asking that these vaccinations be required in schools, or at the very least to allow school divisions to make those decisions?
Yeah. I don't know that we would be in a position of advocating to make them mandatory from a health perspective. I think that that decision lies with the individual, with the school boards. And, you know, if there's information that we would be able to provide in terms of a health perspective, we would be, you know, that would be sort of in our purview. We could, you know, collaborate on that, but I'm not sure that we would be in a position to be advocating on that particular aspect.
I can say for the I can speak for the chapter. I can't speak for national. National AP hasn't taken a position either. I think first safety day is not there, so I don't know that we're in a position to say anything about a mandate. I think once safety day is there, I mean, obviously we will want every child that can get it to get it. I think the mandate question is a more challenging one. Obviously, the APs feel strongly about other vaccines as well, and we're not against the mandate. But I think, in all honesty, our focus right now is just getting it through approval and getting it out as quickly as possible.
Yeah, I mean, I ask because as we're going forth with these intensive communications efforts, this is the other piece of that, is how much we're going to keep communicating when, at the end of the day, you know, people can still, you know, they have that flexibility to do it. And so this is just something that's coming up in our circles. And so I appreciate just kind of hearing at this early stage where you might be, or your organizations might be. Also, just a question about supply issues. Is there anything about supply availability that you're seeing already start to come down the pike that could inhibit the way that we roll out the plans? You know, the best laid plans are, you know, see how long they last, but I'd appreciate you sharing anything about supplies. Thank you.
This is Colin from the health department. As we are doing our planning at the local level, there is obviously planning going on at the state and federal levels around allocation. So I don't have an update on our allocation, but I do know that this is a priority regionally at the state level and nationally.
Okay, and then just lastly, getting back to the instructional component, Dr. Martin, I know that you spoke eloquently to our school board earlier this year about the need to get students into in-person learning, and I'm just wondering, can you speak to what the guidance is from the AAP about the length of time paused or quarantine, and just how to balance those decisions and what school boards and health departments should be considering in making that distinction of number of days? Thank you.
So again, I'm speaking on behalf of Virginia. I can't speak for national. But in terms of our school health task force, we are in support of more flexible policies in terms of shortening quarantine with appropriate testing in place. We are definitely in conversation with the Department of Health about doing things like test to stay, which other states have implemented as well. And understandably, the health department takes a conservative approach because they want to ensure the safety of kids. But we also are looking at a more global in terms of what the impact on kids has been being held from school. So we're definitely, and I know, while National hasn't taken a position, I know even our president, Lee Beers, has spoken to Congress favorably as one possibility of test to stay. I think it's difficult because we don't have data yet, but I think we're also using data for other variants of COVID that don't necessarily even apply as well as we may like them to. So we are working a little bit in the dark, but I am hopeful the CDC has pushed for data and may even have preliminary data by the end of this month. So we may be able to even have some information about how things are going in other states like Massachusetts.
All right, next we have Ms. Cohen.
Thank you. I appreciate Ms. Marin asking that question. We definitely would love some guidance from the health community about being able to shorten that quarantine data. Pausing time and quarantine time. My question, and of course none of us have had the opportunity to get to see the communications plan that was sent to us, but I just want to make sure that we're working in collaboration with the county and with Inova. You guys have been amazing all during the pandemic at all the food distribution sites of having a community liaison who's been there with information about the vaccine since its first availability. So I just want to make sure that we're also working as a larger community to get that information out. And I'm hoping that we can all figure out how to work with our partners. You know, we've had McLean Bible, Food for Neighbors, Abiding Presence, Food for Others, Lorton Community, Echo, just a few in kind of our neighborhood who are doing weekend grocery distribution and things like that. So I'm hopeful that we can figure out a way in our communication plan for it really to be a joint communication plan that we're all kind of giving out. I think it's helpful when it's the same flyer and it looks the same way and people are seeing it multiple places to be able to get that information out. And again, I know I beat a dead horse here, but making sure that we're not just communicating in written form, that we are putting out videos that are informational, that we're doing voicemails, that we're finding ways to communicate other than just written language, even when it's in our 200 languages. Those are the basic advocacies on that. I think trying to, as Dr. Boyd said, making sure that our sites make sense for us is going to be huge. I look at Government Center and I'm thinking about about Braddock and Springfield and how lucky we are to have that there and that there's really good public transportation there. So I feel super excited about that. That's not super helpful to my friend in Mason next door. So however we can be supportive of that would be great. Thank you.
Did you want comment or?
Yeah,
So I just had a quick comment on that, and I want to say thank you very much for the question because I really appreciate it. Communications always needs to be multifaceted. We need to make sure that we're communicating in every way possible, through video, through imagery, through campaigns, through posters, through written format, as well as through the verbal, and making sure that we're communicating in multiple languages in the verbal as well, not just in written format, because we know that some of our families do not actually read in their own language, so we need to make sure that we're not leaving anyone out of the communications. That's really, really important. And secondly, the other important factor in this is making sure that we are collaborating and that we have a coordinated communication campaign, and that this is not just an FCPS campaign, that this is something that we're all leading into, and we're all making sure we all have a community investment in making sure that our community gets to that vaccination rate that is particularly around 70% that the CDC count as the requirement for like a safe vaccinated community. So our goal is to make sure that we're coordinating to get our community to that rate as quickly as possible.
All right, Ms. Sizemore-Heiser.
Thank you. I'm going to try to keep my question just really briefly for you all, since I know there's time limits on that, and I'll ask my other questions later. Just briefly, when you're talking about vaccinations and the Virginia Health Information Systems and to where vaccines are tracked, and I understand that there's a website now you can go on and print out your vaccination status if you've lost your card. The question I have is, I do know of people, and I'll say my stepson is one of them, so I know of family members who have gotten vaccinated, lost their cards, and they got vaccinated at a CVS, and their information wasn't on the website. And so my concern is, as families are getting their children vaccinated, which impacts the pausing and quarantining, right? Because if you have children who are fully vaccinated and asymptomatic, there's a different process and short in length. Are you aware of any of these issues of vaccines being administered at certain sites and then the information not being uploaded? And if so, are there plans to adjust that to make sure our families have access to the children's status if needed?
I mean, I'm happy to speak a little bit in terms of, in terms of general vaccines. It is a system for physicians that's not required yet. As of the 1st of next year, it will be. So all providers vaccinating will have to have their data put into the VIS system. Pharmacies, to my knowledge, are required now to do that. So for all vaccines, not just COVID, I mean, everyone's required to do for COVID, and that's part of the sign up that we do as offices giving. But to my knowledge, pharmacies are actually, they voluntarily did that, but they're required to enter vaccines. There may be a time lag is the only thing, and maybe the health department can comment on that. But to my knowledge, that should be there in the VIS system.
I only mentioned because I've heard of several people for whom this has happened, and they've all had to go get revaccinated. And so I'm just saying, so I always want to make sure that in order to gather their information, I just want to make sure.
There may be a time lapse in terms of when they're down, putting the vaccine. So when it's given, there may be, it should be days, not weeks, but.
So are you saying that, I apologize if I misunderstood you,
Yeah.
the physicians' offices aren't required to?
Not yet. So that goes into effect. We advocated for that at the AAP and the Immunization Coalition to.
So that may just be information to give to the parents who choose to go to their physicians' offices, especially since our data seems to show that most parents want to, or more of our parents want to have their children vaccinated at physician's office, the importance of making sure they don't lose that card.
No, COVID is different. COVID,
Okay.
they have to. But other vaccines at this point don't have to. But COVID, uniformly across everyone should be.
I misunderstood. I appreciate that. And thank you for all your work you're doing, collaboration you're doing with us to provide this for our students and families. Thank you.
Mr. Brody, looks like you wanted to step in.
Sure. Just following up on what Dr. Martin said, for COVID vaccines, it is a requirement to input into VIS. The initial provider agreement, which is what the provider signed, is roughly a 24-hour turnaround to get the data into VIS. But we are aware that no electronic system is perfect. And so sometimes there are issues with uploads from the providers or the pharmacies. And we operate a call center that runs Monday through Friday, and we field these calls every day. So individuals who have lost a card are welcome to call us, and they can provide us with information as much as they can recall about where they were vaccinated. And then we will do our best to verify the information and then provide them with a replacement card.
May I just add that the advice from the call center, and I heard this myself, was to go get revaccinated. So I just wanted to put that out there.
Yeah,
I'm
I would
sure it's
I
a
would be
one-off,
glad
and
to
I'm sure it's a
to
one-off.
hear
I just
offline the
wanted
date and
to
time of the
flag
call, because that is definitely not the guidance that we would
100%. And
we
I'm
would
sure
provide.
it's a one-off. I just wanted to flag this. I just wanted to make sure that, as we're communicating, telling the parents the importance of keeping that card and keeping copies and everything else. That's all I really wanted to flag for this conversation. I know there's a lot of moving pieces to this here.
Thank you, Ms. Asmerheiser. Ms. Tolan.
Yes, thank you very much for being here today. I will add on one quick question for those of my colleagues. As we're moving into flu season, on top of dealing with COVID-19, I was just curious as to the guidance that you're giving parents for children. If they, we want kids to get flu vaccines and we want them to get COVID vaccines, and how maybe our communication plan could, help with both of those situations.
We're actively giving now, so, and the important message is that the COVID vaccine doesn't have to be delayed. The spacing is, it does not matter. If it's 3 days after getting flu, they can get a COVID vaccine. So it doesn't impact, because I've had a few families ask about that, whether that's going to delay them being able to get the COVID vaccine. It can be given at the same time. And so that's certainly an option for some pediatric offices to be able to do both. And so, yeah, I think communication from at least the offices, we're pushing both things when they're eligible for the COVID as well.
Right. Yeah, I think as a district too, just for continuity of education, we know flu can be an issue for us. So we may want to consider that in our communication plan as well. Thank you.
Ms. McLaughlin.
Thank you. Again, given you're here with us a short time, I'm going to focus my questions directly to the health experts here. I really want to capture what Ms. Marin, my colleague, emphasized here, and Ms. Cohen reinforced. We've got to use the global data, yes, on Delta variant, to understand what is the best public health practice for when we pause or quarantine a child and have them out of school. And I really appreciate that the AAP at the Virginia level is recognizing this, but I really would like you gentlemen, and also Colin, Brody, we can't sit on our hands. Fairfax County is supposed to be one of the most sophisticated counties in the country, waiting on Massachusetts or waiting for other jurisdictions on how to use test and stay, how to, shorten the quarantine when a child is 8 to 10 days out, they test negative, and they're still sitting home for 14 days. So I'm pleading with you, anything you can tell us here today to get this school system to mitigate the loss of instruction in kids sitting home, working parents being affected. I really would love for you to share with us today, because this board wants to be proactive, but we seem to not have this proactive action being taken, and we can't wait much longer.
Yeah, I don't know how I have much to add. I would say we're in support, working with the health department, working on a plan to do that. We're open to that. I would agree. I think, as pediatricians on the ground, we're used to having to sometimes make decisions in the absence of data. But we also know that by the time the data comes, it's often outdated and it doesn't reflect what's going on at the ground. And we saw that with the mental health issues in the spring. Because at the beginning of the year, we said this is what's going to happen. Of course, that's what happened. and it was unfortunate. It was something we do think could have been avoided by opening schools early and safely. But it's understandable. I would love to, everything I do in medicine, I would love to have evidence backing it, but it's not always possible. And there's the flip side is that while you're protecting against one thing, you may be causing other negative impacts. And you're taking a best guess at what those look like. But I think we have some experience, at least with kids being outside of school, knowing the decrease in learning that's occurring, as well as the mental health aspects of that we've already been through that and know what that looks like. And I would stress importantly, as particularly on the mental health in these young kids, those kids that suffered those harms, while we can make them, we can bolster them to be in a better place, the damage that's done is done. That's toxic stress to the brain. The brain will not be going back to normal, and we can work with them to improve the condition, but it's those harms that came are irreversible.
Mr. Brody, you're with the health department, correct?
I am. I oversee our mass vaccination campaign.
So can you please share with us an answer to my question? What can we possibly do in a proactive manner to get where Loudoun County is and other school systems are, which is with a kid who tests negative at day 10, why are you still guiding this school system to stay closed until day 14?
Respectfully, I would say that is outside the lane of the mass vaccination campaign. That is more of an epidemiologic question, so I can't provide an answer right now. In general, public health provides recommendations, and then the organizations we provide recommendations to make decisions about how to implement.
But I presume the public health department is making recommendations based on science and evidence. So I realize you can't answer my question, but are you, I know, but I would like to make sure that he at least answers the question. Are you willing to?
It's not his area of expertise, Ms. McLaughlin. I think maybe we can come back to that.
Ms. Omish, I just simply wanted to get an answer to the question I asked prior, which is, are they willing to work with the gentleman sitting here with AAP for us to be able to reduce the quarantine period for our kids? Are they willing to do that? He says they are willing. I want to know if the health department would be willing to do that.
Mr. Brody, I think I heard you share that you might not be the person equipped to answer that question, given your area of expertise for the conversation today. I'll give you the opportunity if you want to say anything else.
Thank you. I would say that the health department and FCPS have been engaged on this response to the pandemic for the last 2 years, and so we're obviously open to discussion, but my area of expertise is in vaccine operations and logistics, and so I'm not able to provide more of an explanation for some of our epidemiologic recommendations.
Okay, thank you. Ms. Pekarsky.
Okay, thank you. I want to thank all of you for being here today. Dr. Martin, as you said, keeping kids safe and in school has always been kind of what we do here, and it has been quite difficult. And I'm just so thankful that we have this group here collaborating right now, giving us the best guidance, because at times that just has been all over the place or not clear. And it's just, I'm so thankful that you're here today, and we are going to have a successful rollout of these vaccinations and see our way out of this pandemic for good for our kids. I have a question for the health department. The total cases and average weekly length, is there some difference depending if you're dealing with the elementary school versus the middle and high school in terms of the length of time? Do you have any more data around that?
I would have to take that back to get an answer.
Okay. Dr. Boyd, I don't know if you...
And I don't know if you want me to answer that now or go back to it. Since my mouth is on, I'll answer it now.
Just quick.
Just generally, we can go back and look at elementary or secondary, but what we will say is that elementary, typically, we know we don't have the ability to filter students out through that, exempting them from the quarantine process, if you will, and being fully vaccinated and asymptomatic. And so a case is not closed until all potential close contacts have been addressed. And so by and large, we do have bigger cases in terms of the number of persons at elementary than secondary, just because they don't have the access to the vaccine as of yet.
Okay, thank you. I think everything else has been answered, and I do thank you all, and we can't wait for the vaccine.
Ms. Keys-Gamarra.
Thank you. I know we're trying to respect time for our experts, and I really do, as my colleague, Ms. Pekarsky said, we really appreciate you being here. But I know the parents are listening, and I'm concerned that there was a question regarding mandating vaccinations. And so I'm wondering can anybody outline what we have to do now, or how that process is for mandating vaccines for our schools? So the parents understand, because is there anybody here who can outline that? Well, I want the parents to hear it. So currently we have vaccines that are required.
Yes.
Right?
The state requires certain vaccinations for school entrance requirements. At this time, COVID is not a school entrance requirement, meaning that students would either have to be vaccinated or have an exemption to attend school. And so I think the question that Ms. Marin was asking about was advocacy in that area, and that decision has not been made at this time. And so students are able to continue to be in school and participate in school in the absence of the COVID vaccination. But again, as a matter of public health and trying to work towards herd immunity, we do support and encourage families to access the COVID vaccine when it becomes available.
So the purpose for my question is, sometimes I think when we hear the questions, people will say the school system is doing a certain thing, and that's not quite accurate. So at this point, parents are simply being asked to support this process. I just wanted that to be clear, to avoid any future letters. I appreciate everybody being here. Thank you.
All right. With that, I think I'm going to take my turn. Thank you all for being with us today. Obviously, we can't be successful at this without a county collaboration, and we're appreciative of our partners joining in that. To follow Ms. Keys-Gamarra, if we eventually are talking about potential mandates and this and that, I did want to ask what you all see to be promising room for alternatives. I know some folks have concerns around that. We've heard it certainly as a school board. But what are your thoughts around alternative ways to potentially get kids there safely if that poses a problem for them? Vaccines specifically.
Yeah, I think we're kind of misunderstanding. I'm not sure we understand the question. You mean barriers to them getting to sites?
No, I'm sorry.
I'm sorry.
So for those who have concerns around the vaccine and potential mandates, right, for various reasons.
So what are we trying to accomplish? Get them to be along with mandates? Or
No. Alternatives, the pros and cons of alternatives that you may have seen being successful that school systems can consider as options.
Do you mean like vaccinate or test with
Right.
regularity, that kind of
Right.
what some of the employers are doing?
Or the antibody,
I mean, I know that there's a lot of science behind that, and I'm sure Dr. Martin could speak more to it, but I would say that Inova, as an employer, was questioned about that as an alternative. We're one of the employers that has a mandate because we're healthcare workers, but even those not at the bedside, we thought it was very important that that mandate be in place because we are setting a standard for our community as a healthcare provider, regardless of if you're a coder and you work from home or if you're a nurse. I do think that it was our perspective that testing as an alternative to vaccination doesn't provide the same immunity bubble for the community that you need in order to reach that goal. So I don't know if you can speak more to that.
No, I would say herd immunity is one consideration, and if we all need to be in on this, and that's a question that often gets asked with younger kids with the lower rates of more serious disease is what's the purpose of that? And we all know flu season happens every year, and where does the flu start and where does it go? It goes from the schools into the communities. It spreads like wildfire, and this is the same. So we are protecting, it's not just about one individual, but we're protecting our grandparents, our loved ones, and people we care about. Alternatively, I mean, I will say that, yeah, there are other layers of protection that we're using now before vaccine that would still be applicable to those who ultimately choose not to. Mask wearing being first and foremost the most important. And I know, and you guys will be talking more about testing, as surveillance testing as another method. And there's many different ways. I can't speak to one. I mean, there's different ways that have been, many different ways of being pool testing and individual daily testing. And I mean, there's a lot of different ways that can roll out, whether it's PCR, antigen testing, so it gets complicated. But I mean, yeah, I mean, my hope is that everyone gets vaccinated who can, first and foremost, and then alternatively for those who can't, for medical reasons, then and using some of the other methodologies for mitigation.
Thank you. And certainly a proponent of the vaccine, just wanting to make sure we don't leave people behind as we move forward. I wanted to also ask if you could catch us up in speaking to the importance of the vaccine on some of those hidden impacts. I know there were some early studies, talking about things that we've seen in children that weren't the case in adults, just to remind us again of the importance of the vaccine for those ages.
Sure, and ages meaning the 5 to 11 crew, or
Yeah.
we're about to do, okay. Yeah, so no, I mean, I think, we are still seeing some, we're still trying to figure out in terms of things like long haul symptoms that kids are having in higher numbers than we expected. There's the multi-system inflammatory syndrome that and you guys could probably talk about because you're seeing them in the hospital that are there. And the hard thing with this is, I mean, the reality is these are often healthy kids that had nothing predating. I think a lot of people are like, oh, my child doesn't have asthma, so he's okay. And it's just a random, it's often random, the kids that can. It's not just and that happens with flu as well. So there's definitely those impacts that we're seeing on kids. Myocarditis is, as much as we talk about the vaccine, myocarditis with the disease is far, far higher in magnitude that we see. And we're still following kids with that, not knowing where that goes long term. So it's always interesting to me because people do ask about the vaccine and the concern about long-term side effects. I've met with so many infectious disease specialists and had these informal conversations. I can't think of a single vaccine where I saw a side effect that occurred after a month. You just don't see it. And the experts, the people that study this stuff and live in this land, I mean, it's just like, I know people are worried about long-term. I can't give you one vaccine where we saw something a year later, 2 years later. It's always within weeks of that initial inflammatory cascade that happens. And so, that's not true of the disease. And I think there's still a lot of unknowns we're going to discover, unfortunately, as we go.
Thank you so much. Wanted to make sure that's abundantly clear for folks. So as we move into the rollout phase of this, just in terms of managing expectations, what are some of the inevitable shortfalls that we anticipate witnessing, again, to set those expectations for the community around this, whether that's Inova or whoever wants to step in?
I will speak for Inova, and I know the conversations that we've had with our community pediatric partners is a far different issue than probably what the rest of the country is concerned with, is that there's a pent-up demand of very excited families to get vaccinated. And so we're anticipating the first few weeks are going to be very hectic, which is a very good problem to have in our region of the families that really, really want to get their children vaccinated. So there may be a lot of offices, our own practices that have some initial wait times that we have to deal with. And I think that that's why we've all been talking in order to make sure that we're trying to hit every family possible from every angle possible, whether it's a mass vaccination center, a primary care office, and ensuring that all of those other community resources are available. I will say that with this age group, if you look at other vaccine efforts like flu, some of the places that are available for older kids and adults may not be available for kids, which may create some additional strains. Like right now, you can walk into any grocery store or pharmacy and get a vaccine. That's probably not the case for a 5-year-old. And I also think that most moms and dads are not really going to be super excited about all of those alternatives for their child. When you consider they usually like to be able to say, like, let's sit on my lap, let's do this together, let's feel good about it. So.
Yeah, this is going to be a time of patience. And so I will tell you, our offices are kind of overwhelmed already. And so it is something I would ask the community to be patient. We're trying to retain staff, and we're losing them like off the charts right now, like never seen in my entire career. And so that's going into, we're doing the planning, we'll get the messaging out, but people are going to need to be patient. It's going to take time. There's going to, we don't, as much as I think supply is going to be there, whether it's going to be there at day one, I don't know. I don't think we know that yet. And then also capacity is going to be, I mean, this requires a little more skill and patience with kids. And so it is going to take us a few weeks to get through. I don't think it's going to be months, but I do think it's going to take several weeks to get through everyone who wants it. And so we just asking for patience and understanding.
Absolutely, thank you. And I imagine did you want to chime in? Sorry.
Just to underscore, I mean, that's the value and the effort that we've undertaken in the last couple of weeks with the superintendent and his team, is to have this collectively so we know what the general community plan will be, and we can communicate that up front. So the parents aren't like, oh my gosh, the EUA has been authorized on a Friday, where do I go get it on a Saturday? There's not a panic and overnight thing. The whole intent is to communicate this up front so the parents can make their own decision. Okay, what's going to be the closest to me? Can I get an appointment with my pediatrician? If I can't, maybe the mass vaccination clinic closest to me is going to be my next best option. Let me make an appointment and do that. And I think as we've heard earlier, the number of vaccines may not necessarily be a concern, but it's the appointments and the availability of being able to sort of have the patients and waiting. Not everyone's going to be able to get it maybe in the first weekend or first week. It will be a rollout process with the size of this population, but everybody should be able to get an opportunity to have a shot or have one brought to them ultimately as the plan steps out further into the community.
Yeah, thank you all so much for that response. And I think that's something we have to continue to think about, colleagues, that we remind the community in anticipation of this to address what we know is going to be a bottleneck and something with plenty of risks and challenges, as it was the first time around with adults. My final question, being mindful of time, you mentioned often having to make decisions without data. And this is something that's a reality of decision makers, our board having to be in situations sometimes too. I wanted to ask you as to what principles you lean on for that decision, for those sets of questions, for that kind of decision making that may inform our ability to make decisions in similar situations.
That's a tough question. I'll answer that in 30 seconds. So, I think in medicine, we're often relying on similar situations. So, and I think there was a mention of global data. So there are experiences with some things that we haven't done in the US and other places. But it's kind of, you look for as much similar situations, both what you've experienced, what you've seen in your own place, and then other places that may not perfectly align, but have some similarities that you can pull information from. And then you pull all that together and you pull your experts together and you make a judgment. That's my short answer.
Imperfect decisions for an imperfect world. Thank you so much. I know, Dr. Martin, I want to be mindful. We are just at that 12:30 mark, so thank you so much for joining us. Yeah. And with that, we will...
And thank you for all you're doing, too.
Absolutely, thanks. We can resume our presentation.
I don't know whether all of our members can stay. I don't know how long everyone can stay, to be honest. And if you can stay a little bit more, I know, that would be wonderful. We're going to move to the testing section of our presentation. I do want to make one comment, though, beforehand, if I could. And I'll let Ms. Omesh then deal with the two board members who have their placards up. We are continuing to partner with the health department. We've talked to the health department about the quarantine length. Their belief is that 14 days remains best practice. Yesterday, Dr. Lori Furlano was at a conference I was at with superintendents. She expects that the CDC will be releasing new data around quarantine. And I asked that new data not only be released, but come with a single recommendation for the Commonwealth of Virginia instead of asking school systems to pick three. We need to have one clear overriding guideline. And I'll simply say, as we speak, CNN is reporting that the CDC is reviewing tests to stay instead of quarantine. So I think a lot is developing, as it always has during the pandemic. And I'll be glad to partner with the health department on the latest information we get from the CDC and VDH and update you at our next appropriate time and place. Thanks.
So again, thank you to our health partners who really, as you see, have worked very closely with us around the vaccination effort. And as we know that while we're waiting for the vaccination to roll out, it'll take some time as we work closely to give students access to the vaccine. We also know that some families may want to wait a while to learn about the vaccine. And so we are implementing a testing plan, which we'll begin talking about now, a COVID screening testing plan. Before we begin our discussion, we want to do a quick reminder of just what the different types of testing are. We'll spend the bulk of our time talking about screening testing today, but I do want to make a reference. We'll make a reference to diagnostic testing later in the slide deck. So just as a brief review, screening testing is intended to identify unvaccinated people who are asymptomatic and do not have known, suspected, or reported exposure to COVID-19 so that they can be isolated to prevent further transmission. Diagnostic testing is intended to identify infection in individuals who are symptomatic or who have a known exposure to a COVID-positive case. Again, our primary focus today is on screening testing, which again is testing of unvaccinated persons who are asymptomatic and who do not have known, suspected, or reported exposure to a COVID-positive case. Starting next month, we will begin screening testing as a layered prevention strategy to help promptly identify and isolate cases and quarantine those who may have been exposed to COVID-19 who are not fully vaccinated. As Dr. Brabrand shared earlier this morning, our transmission in schools is low, but our goal with screening testing is to further reduce the spread of COVID and the need to pause, quarantine, or isolate students and staff as a result. The screening approach that we will use will be aligned with CDC's recommendation for screening testing in schools. As you'll see on the slide here, we are going to partner with a third-party vendor, and we are pleased to announce that we will be partnering with Longview International Technology Solutions. Just to provide a brief high-level overview of Longview, also referred to as LTS, Longview is an acknowledged and award-winning Level 3 appraised government services firm. They focus on delivering first-class healthcare and consulting solutions to federal, state, and local agencies. LTS has more than $1 billion in current and completed public sector contracts to deliver healthcare project management services and support the nation's response and customers' pandemic needs. Over the last year, LTS has combined their deep expertise in healthcare, technology, and analytics with COVID testing and vaccination best practices to consistently deliver industry-leading turnkey COVID-19 testing and vaccination services. Their solutions have been made an industry leader in delivering mission-critical turnkey COVID-19 services. LTS has a dedicated healthcare services practice that's been delivering mission-critical project management, direct patient care, implementation, and program project management operations for over 15 years. The health services practice is grounded in support of Department of Homeland Security, Department of Health and Human Services, and Department of Veteran Affairs, Department Health Agency, and Department of Defense. Their turnkey COVID testing services are designed to maximize testing throughput, ensure the integrity of the specimens collected, and to quickly return test results to patients. LTS has experience with working with state, local, and education contracts in a number of states to include Michigan, Ohio, Virginia, North Carolina, South Carolina, and Georgia. A couple of key highlights regarding LTS is that they serve over 600 K-12 schools regarding COVID-19 services, over 100 public and private colleges and universities with COVID services, have over 10,000 COVID-focused events, and have over 1,000 personnel deployed for COVID-19 testing and vaccination. Again, just a very brief overview of LTS, but we are pleased to be able to partner with a third-party provider so that we can respond to the pandemic and allow our teachers and our staff to focus on teaching and learning in schools. As we move forward to look at an overview, we're going to talk to you this afternoon, about who will be participating in screening testing and the type of tests that will be used. Our screening testing will be administered again by LTS and will focus on 3 key groups that have not been fully vaccinated: students who have not been fully vaccinated and staff who have not been fully vaccinated. Fully vaccinated students and staff will not participate in screening testing. First, we'll be conducting weekly screening testing on a random sample of students who are not fully vaccinated. Parents who wish to have their unvaccinated children included in this group of random screening testing will need to register their child and provide parental consent. Each week, LTS will use a list of students registered for the screening program and will randomly select a group from that list for screening testing. Students that are randomly identified for screening will receive a PCR test at their school during the school day that will be administered again by LTS. The total number of students that will be tested at each school and the frequency that a student would be identified for random testing will vary based on the number of students that are not fully vaccinated and the number of parents who provide consent. We estimate that approximately 11,000 to 12,000 students will need to be tested weekly at the onset. The second group that will participate in screening testing includes all of our active VHSL student athletes who are not fully vaccinated. As a reminder, we require that all students who are participating in VHSL athletics who are ages 16 and older to provide documentation that they are fully vaccinated, and those that are between ages 12 to 15 to either provide documentation or that they're fully vaccinated or submit to regular testing. The weekly screening testing for student athletes will include all active student athletes who are ages 12 to 15 who are not fully vaccinated, and all active athletes ages 16 and older who have a medical or religious exemption. Parental consent, again, is required for participation in screening testing. Student athletes will be given a rapid test and will receive their results in approximately 15 minutes. If the test is positive, it will be followed up by confirmatory PCR tests, as rapid tests can sometimes be inaccurate. Based on our current data, we anticipate that approximately 2,000 student athletes will be tested each week. Our last group that will participate in screening testing includes staff members who have not provided documentation of being fully vaccinated. Staff will also be given a rapid test in which the results will be available in 15 minutes. If the test is positive, again, those staff persons will receive a confirmatory PCR test. We anticipate that approximately 3,000 staff members will be tested weekly at selected sites throughout the county based on our current data. Again, this slide provides a high-level overview, and we will now talk more specifically about each of the groups that will participate in our screening testing. On the former slide, we share that screening testing will be available to our student body that is not fully vaccinated who have parental consent for participation. Further, we share that testing of our student population will be done through a random sample with a minimum target of at least 10% of students in accordance with CDC's recommendation. This slide provides additional details about how students will be identified for random screening testing. Let's look at 2 different sample elementary schools that both have 500 students enrolled, of which none of the students are fully vaccinated. In accordance with CDC guidance, our goal is to screen at least 10% of students who are not fully vaccinated at each site. For a school with 500 students that are all unvaccinated, our target would be to screen 50 students each week at that site. Now let's see how this plays out differently depending upon the number of parents that provide consent. For ABC Elementary School, 300 parents provided consent for screening testing. This means each week a third-party provider, LTS, would select 50 random students from that group of 300 for testing. In this example, an individual student may test on week 1 and week 2, but not on week 3 or week 4, while another student may only be pulled once for testing during that same 4-week period. Because it is random, the frequency will vary for each student. In looking at XYZ Elementary School, only 20 parents provided consent for screening testing. Because our target goal is to screen 50 students each week at that site, and the school had fewer than 50 students registered for screening testing, all 20 students will be tested each week. Families have the ability to enroll their children into the screening program at any point and can withdraw consent at any time as well. That means the pool of eligible candidates for screening can change from 1 week to the next, impacting the frequency that an individual student may be tested. So if XYZ elementary school parents share how much they love the screening program and 80 more families signed up, the initial 20-student pool would become a pool of 100 students. Since we do not currently track COVID-19 vaccination data for individual students, we are using the county vaccination data to approximate the number of unvaccinated students at middle and high schools to determine how many students should be tested at each site weekly. Because our middle and high schools vary by size, the target number of students for weekly screening will be different from school to school, but the assumption that we will use for our percent of unvaccinated students will be consistent across all middle schools and consistent across all high schools. Families will be provided access to an online registration portal managed by LTS to register their children and provide consent for participation in our random screening testing. Multilingual supports will be provided to families who need assistance with registering. Participating in the random screening testing, again, is optional, and only students with parental consent will be tested. We are planning to do a staggered implementation with our screening testing. The random student testing will begin for elementary schools the week of November 8th, with the remaining school sites, middle schools, high schools, and our centers, starting the week of November 15th. We will not be testing at every site every day. This testing will occur at all schools at sites on a rotating schedule, and we are working with our principals to ensure each school is set up to support these efforts. While LTS will be conducting the testing and sharing the testing results with our families via an online portal, schools will have responsibilities regarding the testing, to include things such as identifying the appropriate space for testing, that being indoors or outdoors, directing identified students to the designated testing location, providing developmentally appropriate supervision and supports for students during testing, contacting families of students that test positive to notify them that they are paused, and submitting the red caps for positive cases, which, as a reminder, is our current process for initiating the contact tracing and case investigation process with the Fairfax County Health Department. Schools will get a list of students who have been identified for random screening or random testing 48 hours in advance of the scheduled testing event. We will begin screening testing of our VHSL student athletes on November 1st. This includes our athletes who are actively participating in sports, tryouts, or out-of-season practices. Student athletes that are required to participate in testing will be flagged so that they are not pooled in addition for our random testing with our larger student population. We are working with LTS to align the testing windows with practice times and buildings to allow testing to occur after school and prior to practice to the maximum extent possible to limit disruptions during the academic day. If a student athlete who is not fully vaccinated fails to participate in weekly screening testing, they will not be eligible to participate in the next week's activities and will be ineligible to participate until they provide an update of a negative test result. At this time, I will now invite Mr. McDonald, our Interim Assistant Superintendent for Human Resources, to provide some additional details regarding staff testing. Mr. McDonald?
Thank you, Dr. Boyd. To date, 92% of our contracted employees have responded to our vaccination survey, and 97% of those respondents are fully vaccinated. We are working on some additional targeted communications to increase the response rate. However, those employees who did not respond to the survey will be included in the testing pool, along with those employees who indicated that they are not fully vaccinated. Employee testing will occur at 9 sites spread throughout the county that will be administered by our third-party provider and are separate from the student testing happening at our schools. These sites will be open Monday through Saturday with variable hours spanning from 7 a.m. to 7 p.m. on Monday through Friday and 8:30 a.m. to 3:30 p.m. on Saturday. FCPS will not be providing subs or additional compensation for time spent testing, and employees will be scheduled for testing accordingly. Testing for contracted employees will begin on November 1st, and testing for our hourly employees that are currently working will begin on November 15th. Information will be provided to those who are required to submit for testing, including a link to sign up for appointments for the testing. Communications will also be provided to the supervisors of those employees detailing the expectations. And now I'd like to turn things back over to Dr. Boyd.
As noted in our past few slides, we will be working closely with LTS to provide screening testing for multiple stakeholder groups. In addition to the screening testing, we are working with LTS to provide additional services following the implementation of screening testing. Our future plans include providing diagnostic testing for staff and students to support those who have COVID symptoms or who may have been exposed to a school-related case and are having difficulty accessing diagnostic testing. In addition, LTS will be able to provide vaccinations for COVID-19 as well as required school entrance vaccinations. All services for students provided by LTS will require parental consent. Our goal is to eliminate as many COVID-related barriers as possible through a partnership with a third-party provider so that our staff and students can focus on teaching and learning. At this time, I'll turn it back over to Dr. Brabram for additional updates.
Thank you, Dr. Boyd, and I just want to thank you for all the work you and your team have done to bring this robust testing program to Fairfax County Public Schools. We look forward to partnering with LTS, who has an amazing track record and will be a great partner with us to effectively implement testing for our students, our student athletes, and our staff. I just want to wrap up here. I know we're a little bit behind, but wrapping up, I do want you to know, while so many things have been different over the last 18 to 20 months, we are going to do one thing that is a return to normal. We are going to return to having the first 5 days of inclement weather days be traditional inclement weather days, or as they're commonly called, snow days. We know that unanticipated weather events often cause operational issues, but I also need this board and our community to know that we are dealing with now, even under normal weather conditions, significant operational challenges with subfill rates, with bus drivers, and in other positions. To be honest, I continue to be concerned even about our day-to-day capabilities of operations, especially in weeks that are shortened, and at some of our breaks. We already have teachers putting in leave for breaks coming up into the spring, including spring break, and we're seeing higher numbers that are concerning to us. We're forming a work group, and I have plans to bring additional updates to you when we have convened that work group to think through how we can problem solve and minimize those impacts and bring you ideas. But as we move forward for the winter and anticipating inclement weather, this will allow us to minimize significant, severe operational impacts, and it will also give us additional time to carefully plan to prepare for the transition on day 6 to virtual learning for our students, in alignment with the General Assembly law that gives us the flexibility to do that. Finally, I just want to mention from our last board meeting, thank you again for your motion to support additional support for Dr. Boyd in this unprecedented last 18 months, using ESSER funds to be able to provide her additional support. We have posted a draft job description, and I hope, unless I hear otherwise from the board, it is my intention to move forward with advertising for this position. Finally, I just want to wrap up and say the last 19 months, I just joined superintendents face-to-face across the Commonwealth for the first time. It has been hard on every school system in Virginia. Students, teachers, principals, staff members, superintendents, school board members, all of us. It's been hard on families. It's been hard on all of us. But I hope today, as you listen to this presentation, as you saw our regional partners here, who are still here with us, that each of you can have hope We have a vaccine just weeks away that will be available now to all of our children in Fairfax County Public Schools. We are seeing community transmission rates continue to decline from the rates they were at the beginning of the school year. And I believe that we are finally seeing the light at the end of the tunnel. Vaccination has been the tool to conquer COVID, and we have the ability now in this community to come forward with the highest vaccination rates in the country for not just our adults, but also our kids. I once again want to thank Dr. Martin, Mr. Brody, Mr. Bonnie Uto, and Ms. Fazio for joining us today, for being here to answer your questions, and for their support in a united and joint approach around COVID vaccination. We're entering the final phase in the battle against COVID, and I am hopeful in this moment for Fairfax County Public Schools. Thank you.
Thank you, Dr. Braybrand. Many things to be excited about from this presentation, and it's worth noting. I do want to just time check, colleagues, it doesn't look realistic that we're going to finish this round by any time before 2 o'clock. So just for the program review staff to be aware, and then we may have to shorten lunch, but we'll get there. We'll do another time check midway here. Please, go ahead. Okay.
I do want to thank our speakers. Do know that their timing for this was at 1 o'clock, so if there's anything final, there's 10 minutes of time that had been previously scheduled. I do want to respect their time in joining us today. They're very busy getting ready to implement the plan you've just seen. So I'll leave to the board further
No, certainly. We want to be
discussion.
mindful of that. I see multiple people trying to be recognized. That's fine. Is that what you wanted as well? Go ahead.
Mine was that I had spoken with our chair last night about the time allotment, 2 hours for return to school, 4 hours for program updates. And so it was my understanding that if we found we needed more time on return to school, we would.
Yeah, and I agree, and that's what's happening. Absolutely. I thought the same thing when I saw the, pre-done agenda.
Great, thank you.
Absolutely. So for right now, board members, if you'll lower your placards, I actually already took these names down. And if you have specific questions for the experts in the room, you can go ahead and leave them up, and that way, okay. So we can start with Ms. Corbett Sanders.
Thank you, and thank you all for being here. I read a announcement yesterday that 20% of all new cases are children in the state of Virginia. And so I am concerned that when we talk about the two pieces of this puzzle, and there are actually multiple pieces to this puzzle. One is vaccines, which won't be available until November. Two is the continuation of the mask wearing in our schools so that we can prevent the spread. The third piece is actually the testing piece, but I look at the testing piece as slightly different than the vaccine piece in that the testing piece is really about the me. Am I spreading this virus? Do I have this virus? Am I spreading it? Whereas the vaccine is really about the we. How do we ensure that we don't continue to create opportunities for the vaccine to not only spread, but also to mutate to other possible infections or variants? Am I correct in understanding that?
If you don't mind, I would actually just suggest maybe we do questions first, and then because you only have less than 10 minutes to be here.
That was
Yeah. No, I know. So if you can share all your questions, we'll go around, get questions, and then we'll give them an opportunity to answer.
Oh, okay. And then the second piece of the question is, it's my understanding that that you have a 10 times the likelihood of getting COVID if you don't have the vaccine. And how does that translate into our student environment of children and the likelihood of getting COVID if they are not vaccinated and not wearing masks or, the whole It's the probability issue.
Thank you. Ms. McLaughlin?
Well, I don't know if they're going to be able to answer my question, but I would like to have a deeper discussion when we're talking about this new testing company we're going to bring in, and just your thoughts on, what is this going to actually do for us for keeping more children in school, reducing the times that they're being put out for a close contact, or is this just to literally identify the asymptomatic cases and that's it? Like in any manner that you guys can answer, because we're obviously, again, K-12, not public health. I think there's not enough depth of understanding on what will be the advantages with this testing that we get, the testing service.
Okay. Dr. Anderson?
Thank you. Just a couple, in addition to what has been asked, if you have any feedback on this company itself, or do you believe that all of them are all is equally qualified? I would also like to get your feedback on the plan. I'm not sure how much of it you were part of, or whether was it with just the health department, but just generally, just your feedback. And lastly, I believe I heard from Dr. Boyd that rapid tests would be often inaccurate and would be followed, if it was positive, with a PCR. If you could give some information regarding false negatives rather than false positives, is that something we need to be more mindful of in this testing protocol? Thank you.
Ms. Cohen?
Yeah, I just wanted to ask, and this may be more appropriate for Mr. Brody than our other folks here, but if we know that we're going to have strained resources, are we going to, like we did with adults, put kids who are at high risk? Will they be prioritized with the vaccine?
Okay, so go ahead. Thank you so much for listening. Oh, I'm sorry, excuse me. One more came up. Ms. Tolan.
The question that I had is, our whole plan is based around testing unvaccinated students. Is there any advantage? I know a number of young people with breakthrough cases. Is there any advantage to having part of our testing be with vaccinated students?
So whoever of our experts wants to go ahead and start with answering some of those questions.
So I'm going to go not in order of those asked, but in order of the easiest ones for me to answer. Your question about prioritization of kiddos and how with adults we went with the sicker, the more immunocompromised first. That's absolutely happening, I think, more within the physician practice environment and the parents engaging with that. So in addition to all of the kind of the primary care practices, our complex patient populations and those providers, at least I know of within Northern Virginia, so the kids with cancer, the kids that have had heart disease, the kids are in contact with their physicians, and some of our specialty practices are going to be giving limited vaccine amounts to those kids only. So, the healthy kid is not going to be able to jump in line necessarily. In that line, it's a reserved spot for those patient populations. And the same would hold true within our primary care practices. I would assume that they're also going to probably have some sort of internal prioritization to jump some of those kids to the front of the line. It's actually, I think, nationally 25% of the cases are kids right now, and that number feels like, are more kids getting sick? Yes, because I think this Delta variant is different. We're also testing more often than we were before, and at the same time, so many of our older people are vaccinated, so they're less likely to be getting sick. I think that the point that is important to be made to families is that these other variants that are newer are actually making kids sicker than we saw in the fall. Like, there are just as many kids in the region as there were this wave, like wave 4, is that what we're in now, to wave 1. But we're certainly seeing more hospitalizations and more sicker kids than we had in the past, beyond our hospitals being busier generally with more respiratory and other patients. So the demand on the system is certainly greater. And I think that that's, the likelihood of getting COVID with a vaccine or without, I can't necessarily speak to, except for that, the breakthrough cases are certainly real. I think that we're strained with regards to vaccine availability, but I think the systems, I can speak to Inova system. I'm sure that it'll be the same. There are times when, reagent is available. There are times when swabs are not available. There are times when all of these different components, there's just the same supply chain impacts that we're all seeing in trying to buy furniture and everything else, are straining our ability to get certain supplies. So I would say that the approach for the unvaccinated, if you make that pool so much larger, you're not really going to be getting the likelihood of infection is so much smaller and infection that spreads. We can't really give feedback on the company selected. And I think the feedback that I would have on the plan as the health system partner within the region is that we are very excited to see that diagnostic testing is also in that runway, just because I know that the pediatric practices and our Inova emergency departments have been challenged to try and fit all of the different patient populations that need us into our queues. So, sick kids obviously come first, and then our well visits that we've been managing, but then when a child only needs a test to return because they're in some sort of pause or quarantine, those are our lower priority patients that are obviously still a very high priority because it gets them back into, whatever activity or school it is, whether it's Fairfax County Schools, Loudoun County, Prince William, or all the private schools in the region. So we're excited to see that, and we also appreciate the changes that Fairfax County has made with those return to school forms as of recency, because I think our emergency departments more than anyone appreciate the flexibility there for sure. I don't know what questions I left out, but I'm sure that our health department friends can answer some of them as well.
So this is Colin. Before I jump off, we don't have experience with the testing company, so I can't speak to capabilities there. In terms of the other questions that are more focused on epidemiology, I will take those back and we will provide a written answer based on consultation with our epidemiology team.
Is that all? Okay. Thank you so much to Ms. Fazio, Mr. Bonaiuto, and of course, Mr. Brady for your participation in this portion. We are grateful for your time. And with that, we can go ahead and pivot to questions directed at staff, operational questions, things that we left behind. I know, Ms. Marin, I see your hand. Do you? It seems without objection. Okay, we can go ahead and take a break. Realistically, folks, I do want to take a quick pulse, though. If we do take 30 minutes, this is going to be a challenge for time. So I'd like to consult folks. Option 1, that we go for the full amount. Option 2, that we take 15, okay? It sounds like there are a lot of people who are unhappy with that. All right, we will go ahead and take our 30-minute break.
Colleagues, lunch will be available in conference room 4050 and 4051, and we can continue our closed session there. Yeah, 4050. Yeah, 4050 and 4051 upstairs. Yeah, and we'll continue our closed session there.